Okay, welcome to the International Interprofessional Mentorship Meeting. I am Dr. Kate Barlow, the founder of the program and your host for today's meeting. It's August 20th, 2020. And today, Dr. Joanne Flanagan and Dr. Barbara Demchick is here to talk about early identification for children with autism. Please mute yourselves during the presentation and unmute yourself whenever you would like to ask a question. You can also type your questions into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please enter your name and email into the chat box now, and you will need to remain on the webinar until the presenters are finished. At the conclusion of the presentation, we will have an optional meet and greet. Thank you all for coming, and let's get started. Thank you.
Okay, hello. Barb, do you want to introduce yourself first?
Sure. I'm Barbara Demchick. I'm a clinical associate professor in occupational therapy at Towson University. I've been working with little kiddos and their families for well over 40 years, and I first started working on early identification when Joanne was doing her dissertation. So we go back a while doing this.
And hi, I'm Joanne Flanagan. It's an honor to be here with you today. I am a pediatric occupational therapist. I have over 20 years of experience. I'm a professor now at UTMB, assistant professor, and I had the opportunity to work at Kennedy Krieger where I did research with Dr. Landa, and we looked at babies who were high risk and low risk for autism, and they were followed up to the age of 3 when they were diagnosed. So I'm going to present the research that I did with her, as well as the research that Barb and I are doing since then, looking at early indicators of autism. Okay, so, oh, those lovely babies are my boss's grandchildren, aren't they cute? So the objectives are to discuss the rationale for assessing early motor and play skills and at risk for infants for autism. Kate, the pictures are showing up in my text. Can I move them? Oh yeah, okay, never mind. Okay. To describe the specific research findings related to assessing quality of movement and play behaviors in at-risk infants for autism, and to also discuss the clinical implications for U.S. therapists for practice with early intervention, early screening and early intervention. Okay, so as many of you know, autism is not normally, the median age for diagnosis of autism is about 4.5 years of age. I'm not too sure what it is like in your countries. It may be later, I don't know. I do have a colleague of mine who's in Africa and she says it is much later. So I'd love to hear your input about that. But there is research showing that autism can reliably be diagnosed by the age of 2, but children obviously are not often diagnosed until much later. And of course, the diagnostic criteria focuses on higher level cognitive and language skills and the core features of autism. But there may be signs of evidence of autism earlier, but they may manifest differently than at later stages. So studies suggest that the signs of autism can be identified in late infancy to the 2nd year of life. And most of these studies that have been done with high risk and low risk infants, where they study them prospectively over time to see what are the earliest signs that these babies show that are later associated with a diagnosis of autism. So we know as occupational therapists that families of children with autism have impoverished family occupation. They have increased parental stress and have decreased participation in meaningful activities. So in the research, we see that the earliest indicator of development disruption may be linked to the motor system. And oftentimes it's the sensory and motor systems that are the first signs that something is not developing appropriately in the central nervous system. And this is across the spectrum of developmental disabilities, not just autism. So why should we be looking at early motor skills in infants who are high risk for autism? So we know that infants' movements are very much related to social and communication skills. Motor provides the foundation for them to move, for them to explore, for them to interact with their parents, for them to be able to have graded movement, have it to be timed and graded for them to be able to interact with their parents. We also know that motor skills are really important for cognitive, language, and social development. In fact, Dr. Campos and his colleagues have done studies where they looked at infants who were crawling versus not crawling, and the infants who were crawling actually had better visual perceptual skills, and also actually social referencing too. And he also looked at babies who were walking versus not walking. And you definitely can see that relationship between more advanced motor skills and cognitive and language and social development. So motor provides a window into the developing nervous system and into the developing brain. It may provide a mechanism for us to be able to predict later impairments. There are some really neat studies out that look at neuroimaging and really look out the brain, and we see that white matter pathways are not developing as it should be. They've also looked at functional MRIs, and there are abnormalities in children at 6 months of age who are later diagnosed with autism. So early motor impairment may be a clinical manifestation of these abnormal developments. Okay, so why should we be looking at play skills? Well, early play behaviors include the ability for that infant to be able to explore the environment, to play with objects, to interact with their caregiver, with their parent. So these behaviors may provide valuable information about the sensory, motor, cognitive, and social function of these infants that gives us, again, a window into the early developing nervous system, and that may predict autism. A few studies have looked at play in mid-infancy. Dr. Baranek has looked at that in children from 9 to 12 months of age, but few studies have really looked at it as young as 6 months of age. So we do know from the research that play in infants and toddlers who have autism tends to be qualitatively and quantitatively different from that of children who are typically developing. And Dr. Baranek has done some nice research with this, and she has shown children to have less mature play patterns at 9 to 12 months of age who have autism. But there is that gap in the literature looking at really early movement and play behaviors in 6-month-olds at high and low risk for autism. At least there was back about 10 years ago, and we did this research over the past decade. Okay, so I'm going to present to you now our research on looking at early motor and play skills in these infants at high risk for autism. Again, these high risk infants are infants who have an older sibling with autism. We know there's a high genetic risk for autism and a milder set of impairments, which some refer to as a broader autism phenotype. In fact, there's a recurrence rate of 18.7% in families who have more than one child with autism. So by studying these high-risk infants, we may be able to see those earlier signs of autism. So what we did is the babies were administered the Mullen, which is a developmental scale, and they were administered that at 6 months of age, also at 14, 18, and every few months up until the age of 30 and 36 months of age. So we examined what their performance was in pull to sit on the Mullen. We looked at their head lag at 6 months of age and the later diagnosis of autism. And in the literature, this has been shown to be a predictor of developmental disability in children with CP and also with some other diagnoses. So we wanted to see if there was a difference between infants who were later diagnosed with autism versus those that were not. We also wanted to see whether the presence of head lag distinguished high-risk infants from low-risk infants at 6 months of age. So in our first sample, we had 40 high-risk infants who were followed from 6 months of age to 36 months of age. And in our second sample, we only had low-risk and high-risk infants who were not followed. It's very expensive to do a longitudinal study to follow babies from 6 months of age to 3 years of age. So in our second sample, we weren't able to follow all these babies to look at outcomes, unfortunately. But again, we looked at their clinical judgment of head lag scored from the videotapes of the pull to sit item on the Mullen gross motor scale. And I will show you some videos of that in a few minutes. So at 36 months of age, the children were administered the ADOS, which is the gold standard for diagnosing autism. They were also given the Mullen scales of early development, the receptive and expressive language scale, and also a clinical judgment by a speech therapist or a psychologist using DSM-4 criteria to give the clinical best estimate of whether that child had autism or not. And again, the children were seen several times during that 3-year period. And based on the outcome assessments, they were either diagnosed with autism, with non-autism social communication delay, so they didn't hit for autism, but they did have social and communication delays, or they were the non-delay, they didn't have social or communication issues. So I'm going to show you an example of a low-risk infant at 6 months of age right now. And this is Dr. Anjana Bhatt. She's a PT who is actually administering this item.
Let's try that. Are you ready? Hey, sweetie.
So the baby's looking at mom, and mom moves out of the way.
Good job. Yay. Can you go more? Can you do more? Yay.
So that baby's able to hold the head up and does not lag the head behind. And you would expect at 4 months of age that the baby to be able to not have head lag. And these babies are at 6 months of age. So look at that again. So the baby does a nice job in that pull to sit task. And then, let's see, I can get out of here. Okay, this is an example of a high-risk infant. So we had to use publicly available videos because this is recorded, so I apologize for that. It's going to be a little bit of a lag in getting them set up. But you see the lag, the head lag in that baby quite a bit, quite significantly. I think it's really important when you are looking at this that you position the baby so that there's not someone behind the baby where the baby's going to purposely be looking behind them and purposely maybe lagging their head behind and also looking up at the lights too. So you want to think about those things when you're looking at this. Okay, so we found our results at 6 months of age. We found that head lag was associated with the outcome of diagnostic classification of autism versus non-autism. So the high-risk babies who ended up with autism were more likely to have head lag versus the infants who did not end up with that diagnosis at 3 years of age. Okay. So in fact, we found 90% of our babies, so 9 out of 10 in our group, had head lag. And the one who didn't have head lag did exhibit motor abnormalities. The baby was rigid and had tremulous movement. So I'm not saying that every baby who ends up with autism has motor issues, but in our study of high-risk babies who had autism, they did all have motor issues. I think this is something that definitely needs to be looked at more. So in our second sample, this was the high-risk infants and the low-risk infants that we just looked at 6 months of age. And we did also find that the infants who were high risk were more likely to have head lag at 6 months of age versus those that did not, that were low risk. So in summary, we found that head lag at 6 months of age was more prevalent in the high risk infants who were later diagnosed with autism. And it was also more common in high risk infants versus low risk infants. So what does this mean? So we know as occupational therapists that if a baby has head lag at 6 months of age, they may have low tone, they could have poor postural stability, but it also could be impaired sensory processing too, where they're not responding to the sensory input and they're not making those anticipatory postural adjustments as they're coming up pull to sit. And we do know in the research with older children that they have been found to have difficulty with multisensory integration. Dr. Minshew and Dr. Malol have done some nice studies using the NeuroCom with that. So in our second study at Kennedy Krieger, we looked at the relationship between early movement and early play in infants at risk for autism. Okay, and Dr. Rebecca Blanda is the PI for both of these studies at Kennedy Krieger and Hopkins, and this is approved as part of a larger National Institute of Health funded longitudinal and prospective study. Okay. So we had 58 infants in this study, 12 ended up having autism, 18 had the non-autism social communication delay, so they didn't meet the criteria for autism, but they still had social and communication issues. And then we had the non-delay, a group of individual children who did not have social communication issues based on the outcome assessments that were very similar to what we used in the first study. For play, we use a revised Knox Prescale Play Scale, which is an observational rating scale, and it's been found to be a valid and reliable tool. And we also use Lucy Miller's and Dr. Royd's motor instruments, the time clinical subtest, which looks at atypical positions, and the clinical subtest movement portion, which looks at quality of movement. So with the atypical positions, it's used to code abnormal movement patterns, and it really looks out, is the baby weight shifting? Is there maybe abnormal extension? Is there still primitive reflexes that haven't been integrated yet beyond the time that it should be? Those kind of things. Is the baby kind of glued to the floor? Those kind of things. And it's normed on children with motor delays and deviations, and has been found to discriminate between children with and without motor delays. And then the movement portion of the component analysis subtest looks at the quality movement. It looks at that in each developmental position: supine, prone, sit-in. Many of these babies at 6 months of age are not sit-in yet. And then the outcome assessments are very similar to the ones we used before, the ADOS, the Mullen, and the clinical judgment using the DSM-4 criteria. So we did find that the infants diagnosed with autism at age 3 had lower overall play abilities at 6 months of age, which was pretty exciting to find. Now, we did not find significant differences in the atypical positions and the quality of movement, even though the infants with ASD did tend to have worse scores. It was not statistically significant. However, I think given the fact that you also have other high-risk infants who don't have an outcome, we're finding now in these high-risk infants that they do tend to have motor issues across the board, regardless of whether they end up with a diagnosis of autism or not. So I think that's probably a reason why we're not seeing statistically significant differences in motor, because it's kind of across the board with these high-risk infants that they do have motor issues. We did find that I believe it was 1/3 of the babies with autism had 18R still at 6 months of age. So this could be a sign that the central nervous system, again, is not developing appropriately if these babies are not integrating the reflexes when they should be. We also found a few of the babies with autism having this position that we show here, which is called active head lifting from supine. It really looks like a Pilates position, but the babies are kind of stuck in it. And this has been shown to be associated with poor cognitive outcomes at the age of 2 in the literature. And we also found that half of our babies had atypical repetitive movements in the hand and wrist. And Dr. Demchick has also found that in her studies too. So again, although the motor scores that the motor tests that we used were not statistically significant, we did find motor issues in our children. And the limitations of our study, there's a lack of comparison group. There's a small number of infants that were diagnosed with autism or a non-autism social communication delay. And the revised Knox Prescale Play Scale was not previously used to evaluate play behaviors in infants at risk for autism. We also had to clarify some of the descriptions for reliability purposes. And I'm grateful for Dr. Demchick. She spent hours working with me on this to code tapes for integrated reliabilities, the goodness of her heart. So thank you very much. So from this study, we have spent hours looking at these tapes of babies who are high risk, who end up having a diagnosis of autism. So we have identified target behaviors that we feel are associated with autism. So Dr. Demchick and I have come up with the infant motor and engagement scale, and we're in the process of piloting that. I haven't had much luck trying to recruit on the island in Galveston, but Dr. Demchick has had more luck in Maryland with recruiting for this. We are in the process of piloting the scale and looking at the psychometric properties, looking at content validity, all that. So this is kind of an example of what the scale looks like. An item is the infant plays with toys showing a variety of actions such as banging, shaking, mouthing, and hitting objects. And we definitely see that early on these babies are not showing a variety of movement. So I'm not going to go into detail about how we're developing the test. But we are in that process, and Dr. Demchick now is going to talk to you about her studies, looking at home videos, and then also looking at using the scale. So there you go, Barb.
Okay. So good to be here today. So the first study we looked at was before we started developing the scale. So I came up with a protocol similar, some of which were the same items Joanne had used. You can go ahead and turn it. So basically what we asked ourselves is, in this case, is, you know, Joanne had a whole bunch of kids she had access to who had been studied because they were at risk, because they had siblings that had autism. So they had a ready group of kids. In reality, in spite of the fact that we know that autism runs in families, an awful lot of families find themselves with a child with autism when there is no family history. So we wanted to see, is there a way to look at this in kids that aren't at risk and aren't being systematically followed in the same way? So we decided to look back at home videos of babies at 6 months of age, the same age that Joanne was using. And in order to participate in the study, the child also had to already be over 3, and already have either be darn sure that the child either didn't have autism, the child was typically developing, or did have autism. And we were hypothesizing, again, I had the benefit of her studies to saying that we are going to see differences in movement and play at 6 months of age in their natural setting. The interesting thing is some of these parents already know something's not quite right too. So, I mean, it's really important that we listen to our families when they say, he doesn't play like my other kid did, or something of that sort. Oh, I can't turn it. Go ahead.
Okay.
Thank you. And we did, way back when Grace Baranek had said, over 20 years ago, that home videos are a viable method for looking at early development, because it's a record of what the child was doing. And we can see the occupations of the baby. And you can see also, which is, I think, very worth looking at when you're looking at kids potentially with autism, the interactions, the co-occupations with the parents and children. And we're allowing an examination of play behaviors in natural environments. And the most important part is this is one way we can look at babies that have no previous known risk, because our aim is to develop a tool that can be used with babies without risk, where babies could be screened. So in the first study, these studies are really small. I have no funding, so it's whatever we could recruit, a propulsive sampling from wherever we could get it. Our babies were between 6 and 7 months of age. They were over 3. We wound up with 6 with autism and 9 without. I was working with a group of students, so whoever brought the videos were not allowed to participate in the data collection. So the people that were analyzing the videos, whether it was me or whether it was students, were blind to the diagnosis. So we could go ahead and just look at what the babies were doing. Go ahead, Joey. And this was a descriptive correlation research design. It was a pilot study. We looked first at everything just through observation, but if we thought we saw an association, we wanted to see if there was a true association with outcome. And it put together a protocol that was largely came from Joanne's previous studies. We used the revised Knox preschool play scale the same way she did. But I also added the functional emotional assessment scale, which is an observational tool that has some standardization data that was developed by Stanley Greenspan's his partner Serena Weeder, but also with Georgia Giganji, who is an OT. So I think this particular scale is a good one because it really is looking at qualitative things. We did practice video analysis, and we had to be reliable. We tested before we started really evaluating babies. We used publicly available videos. And there were, as I said, we were blind. Whoever was doing the analysis was blind to the study. Oh, I still can't turn it.
Right.
Yeah. Again, the revised Knox preschool play scale, we looked at each of the 4 dimensions of play that are in that scale, and that's relevant because some of them were more significant than others. Material management is how the child plays with toys. Space management is navigation through the environment. Pretend symbolic is imitation, and participation is interaction with people in the environment, play and cooperation and things like that. The FEAS, which I do want to point out, you can find that online. It's actually most of the book that it's in is online available, and you can easily get a hold of the, if you search functional emotional assessment scale, you will be able to find the actual tool. We were looking at how the baby interacted with the parents and with the toys, their ability to self-regulate, the attachment to caregiver, reciprocal interaction. And there are 2 scores that come from the FEAS, and we use both of them, self-regulation and interest in the world, and forming relationships, attachment and engagement. And we actually used, the FEAS has a cutoff score, so we actually used that when we did it. We also added some of our clinical observations that we had been seeing. Anticipatory postural control. Did that child move, for example, to be picked up or to play a game? We looked at how long it took for the child to smile when the parent tried to get their attention, if the baby required a number of prompts. We also looked at repetitive behaviors. We looked at what Joanne said with the wrists and hands, but we found that there were kids that had repetitive behaviors in the head, in the feet, and their trunk. So, you know, any repetitive behavior at all. We looked at visual engagement, you know, basically how long the baby was engaged visually with the parent. And we also used the atypical positions using the time, just like Joanne did. We said we took some of this out of what she had done. As we said, we first analyzed them descriptively, but there looked like there were a lot that might be significant. So we did a chi-square with a Fisher's exact test. We did it for each of the 4 dimensions of play. We did the total play score, both from the revised Knox. We did the FEAS scores, which were 2 of them. We scored the time atypical position subtest, and we did each of our clinical observations that I mentioned. Because I was using this particular way of evaluating, even though initially I didn't do it this way, we dichotomized all the variables. So instead of, when we put it in statistics, instead of giving the play age of a child, we converted it to 6 months and older or under 6 months. So there were 2 options, and we did that for all of them in terms of, you know, the time to elicit a smile, for example. If it was 3 seconds, we went with, I think, immediate or 1 second, and then more than a couple of seconds. So we did everything by 2 choices. It just made analysis easier. Oopsie, what happened? Oh, I actually cannot see this screen right now. So let me see if I can figure out. I can't see the PowerPoint at all anymore.
Oops. I don't know what.
Here, I'm back. I can see it now. Okay, so this gives you some idea of what we saw, you know, what our months were. So you can see that in all of the scores, they're not all significant, but in all of the scores, the children scored higher in the revised Knox preschool play scale in our typical. Those are mean scores. So those were the typical kids scored higher in all of them. They weren't all significant, though. Statistically, you know, things can also be significant clinically that aren't significant statistically, and that's important to keep those things in mind. You can go ahead and switch it. And here's our scores on the FEAS, which clearly it's in months here, but we later just used a cutoff score, and they were either above the cutoff, at or above the cutoff, or below. But you can see the months are very different or the scores, they're not months, they're very, very different in our typical babies in both of the 2 domains of the FEAS. And here's just some items to give you an idea of certain things that are on the FEAS, and I think it's important because it really relates to some of the things that we would look at. A lot of it looks at social referencing in different ways, like do they look at the caregiver while playing, and if the caregiver or they move away, do they look back at the caregiver? The way they anticipate when a caregiver gives them a toy and how they play with toys. Those are things that we know are important, and they showed a very big difference between the 2. You can only get a 0, 1, or 2 on each item. That's why it says typical 2, ASD, 0.75 or 0.4. You see that they were significantly below. And just some of our observations. So we can see that the number of children with autism that had an atypical position was 2, but out of 6, where none of our typical kids have some of those things. And that's one of the reasons why in Joanne's study, it probably didn't turn out to be significant, because you don't see it in every kid with autism, but when you do see it, the child is the child that was later diagnosed with autism. Similarly, anticipatory postural control, we did not see any of that lifting, moving to get picked up, or moving forward to play a game, or moving your hands up because you know that the patty cake is coming. Those kinds of things we did not see in our kids with autism. Again, similar to the atypical position, if a child, we never saw in either study that we did or hers, we've never seen the repetitive movements in a child that is later typical. They may not occur in every child with autism. In this case, we saw it in 4 out of 6. But when they are there, they mean something. And again, none of our typical babies had it. Our children with that are typical smiled rapidly, and not all the kids with autism did that. Most of them did not. Most of them required more prompts to engage, and most of them were less visually engaged. But that was a less good item. We eliminated that from the future study. You can go ahead.
Barbara, I just have one comment with that. So because I looked at high-risk infants, I did see a few high-risk infants who ended up not having autism who did have repetitive behaviors.
Okay, but we did not because our other group was typical. So it's important to recognize, and that's one of the flaws of our study. I'll be very honest with you. So we don't have an in-between group. So we were looking, and we were doing it on purpose because we wanted to see if if this discriminates between autism and not. There are other groups that indeed could have some of these features, but they weren't there in this study. And again, these are, all this is saying is our significant items. So they were the same ones that were there, but we saw the revised Knox preschool play scale participation scale was significantly, statistically significant, whereas some of the other ones were different, but not statistically significant. The total play age was significantly significant. Anyway, it was statistically significant. Those tests from the FEAS were statistically significant, as was anticipatory postural control, repetitive movements, the number of prompts to engage, and how long it took to elicit a smile. And that's one we see a lot, and I know we're going to talk about that in the next one, but one of the things that was so striking to Joanne in her studies and me and mine is how much work these parents are doing to try to get their kids' attention and to get that response from their kid. And you see a lot of frustration in some of the parents. One of the interesting things we found, and it was way too small a sample to make any judgment on, but I think it's interesting, is that we had a couple of little girls in our study that did not score the way the other kids did. Like we had a little girl who looked like she was socially pretty strong, so she did fine in the FEAS, and we had another one that's supposedly typical. Again, that's how she was reported, which is another flaw in our study. It's a limitation because the parents reported outcomes, but they did not score it, in line with what we expected with the outcome. This is something I think that some of the literature does seem to support, and it's something that requires further study. And I have not gone back to look at these gender differences, but I think it's something that we always should keep in mind, that little girls look different than little boys. And I think there's enough other research coming out that says that. You can go. Oh yeah. As I said, some of the limitations, we had a small number of videos. We don't have a comparison. And the parents diagnose it. They don't diagnose it. I assume they have a diagnosis, but they're the ones that tell us the diagnosis. So clearly those are limitations, and they're big limitations. As Joanne already said, the revised Knox preschool play scale was not used in this way before, but then again, she consulted with Susan Knox, so she told us we could do this and helped us to figure out how to do it. And the FEAS is not usually used for this purpose. It's not designed to diagnose, and it's not designed to be used with babies younger than 7 months, but it really seemed to be a really nice discriminator. So I would continue to encourage its use for this reason. And while I'm thinking of it, it's not a limitation. I just want to point it out to you that the FEAS has a parent scale where you evaluate parents and a child scale where you evaluate children. We only evaluated children, and I'm only comfortable doing that because I don't want us to go back to the days where I was raised in my education, where they said mothers had something to do with why their kids had autism. So we only evaluated, we knew that all the families that participated were involved families. We did not evaluate parents at all. They were all doing their best with what their kids were able to get them to. Go ahead to the next one. So the next study we did was, again, with another group of students, and we started to begin to use the IMS, and it's really in progress. We used the same format. We had 7 infants of males. We only did males because I didn't want to see, I figured we can see if it's good with males, since males are at least 4 times more likely to have autism anyway, so we may as well let's just look at them for right now. We expanded the age range a little bit, but I don't think that was problematic. So we had 8 typical babies, 7 with autism, when we were looking at their videos at 6 to 9 months. And, several of our items showed significant correlation the same way they did before. A lot of our items concerned things like the item that Joanne already showed you about play with toys. So our kids that were later diagnosed with autism, they played. You give them a toy, they play with it. But they tended to play with it the same way each time and not show the variety of play that kids normally do. That we found it, just like we've already said, harder to get these kids' attention. So they didn't smile as readily. They didn't engage their caregiver. If they were playing and their caregiver moved, there wasn't that look of, where is she? Or, so those kinds of things showed significance. The kids that were later diagnosed with autism didn't babble as much either. So we saw those same kinds of things that we had seen with other kids, with the other studies. And again, same limitations, small sample size, and also inconsistent video. I didn't mention that already, but whenever you're looking at home videos, not all videos have everything you want to look at. So we had some missing data there too. One of the things I think is really, really interesting is that, we're always taught that we have to look at statistical significance, but sometimes you learn from things that are clinically significant. One of the things we happen to notice, which I think is interesting, is we had no videos in this group, none, of a parent playing a game with their children, like pat a cake or peekaboo or something like that. There just wasn't any content. Yet we had plenty of content in our typical kids. So it made us start to think, and I don't know for a fact, I can't draw a conclusion based on that, but it does make you wonder whether people were not videoing that in their children because they weren't seeing it. So we can't conclude it, but I think what we need to do is use our powers of observation and ask these questions and say, well, we didn't have data on that. Why is that? Why is it that it was only missing in one group and not the other? And I think that does give us some information, at least of things we should follow up on. So we're going to talk now about implications for practice. And, I think we need to assess these early play behaviors and early parent-child co-occupations. And remember that play, even if I call it play, and all these play behaviors look at movement. They all concern movement because movement and play are intimately connected. So I don't want you to think I'm only looking at play and not a movement. The repetitive behavior, as we have said, we only saw it in kids later diagnosed with ASD. She saw it in high-risk groups, but it's still not, you don't tend to see that in typical children. And again, it is striking how hard parents of children with ASD had to work to engage their infants. And you sometimes, in some videos, we actually saw frustration. Where they're trying and they just can't engage it, and you see them give up sometimes too. So I think that that's a real qualitative thing. That's why you don't see it on a regular developmental assessment. The child does what he's supposed to do. In often cases, he meets a lot of milestones, but it's the quality. These parents are just having to work so hard. And most important is if we identify these kids earlier, before symptoms of something like autism become full blown, we can really cause a change that will impact the child and family occupations. The family won't be so frustrated. They'll learn how to play with their kid. The child will ultimately get into early intervention, and that's where you guys come in, and we get these kids into treatment early, and hopefully we can affect family outcomes, child outcomes, and the bottom line is this: we have to identify them early in order to treat them early.
As Barb was talking about how striking, how hard the parents had to work with the children who were later diagnosed with autism, in the study at Kennedy Krieger, the parents, there was a peekaboo section. So I saw that with the infants. And then there was this one infant who the parent didn't do peekaboo, but did this kind of weird repetitive noise and sound with her hand. And I'm not too sure what that was about. I wasn't too sure if that was the way she was able to engage her infant, where she maybe couldn't do natural peekaboo, or perhaps the mom also was on a broader autism phenotype and did repetitive behaviors. I'm not too sure, but it was interesting to see. But I do think that the parents are really struggling to try to find ways to really engage their infant. And what we also found was it's not so much the presence or absence of behaviors. It's not so much that these babies smile, but it's not the quality and frequency that you would see with a typically developing baby. With a typically developing baby, it's so beautiful to see that peekaboo. And Barb has this beautiful video where the baby just lights up, and we're going to show you some videos of that later on. But, you know, a typical developing baby lights up, and there's that love relationship with that baby and that parent. They're wooing each other, and you don't see it like that in these babies that we have seen that are later diagnosed with autism. So one of my favorite quotes that I came across from doing my dissertation is, we must perceive in order to move, but we must also move in order to perceive. So are these babies not moving because they don't know how to, or they have motor issues, motor delays? Or is there also kind of an information processing thing and a perceptual thing too, which influences whether they're moving or not? So it's an interesting question to ask when we're looking at infant development. So we feel that the development of high-risk infants and also low-risk infants with red flags should be monitored from at least 6 months of age. And early motor variances in high-risk infants may be a useful red flag for later impairment. And, you know, definitely we're not saying if they're showing motor issues at 6 months of age, they definitely run in and get intervention. But I think the primary care physician should be monitoring them. And Barb and I really feel that a lot of these babies, it's not just motor, but it's subtle red flags in developmental domains across the board: motor, social, communication, not really babbling, not making eye contact, but not the way a typically developing baby does. Do you have any comments about that, Barb?
Well, again, we always want to remember that, you know, not all babies are going to be at risk. So any baby, I feel like any baby should be looked at to make sure that they are, you know, developing those signs. And again, it's that we see a lot of those mild motor issues. They can be very, very subtle. I mean, so again, our kids could be very, very subtle. I mean, most people aren't picking up the anticipatory postural control because the baby still does everything else. So they're the kinds of things that are missed. And I think that's important. So actually that brings us to this, these are some of the things that we think everybody should be looking at. The quality of the motor, not necessarily, you know, everybody, especially doctors in the doctor's office, they just look at motor milestones, and most of our kids are going to hit the milestones in motor. You know, so it's not a matter of milestones, it's a matter of quality. And I think that that's so very important. The head lag that Joanne mentioned, the anticipatory postural control that we talked about, many of these kids are mildly hypotonic. They show it more, I think, at, you know, the 6-month age than they do at the 9-month age, but you can often see, you know, a hypotonic sitting posture. They, you know, the rounded, the shoulders, the wide base legs and things like that. And, you know, her statement of passivity, that's an important one too, is that they, you know, and most of these are, by the way, you sort of in your head, you're going to think that these kids should be cranky or something. They're not. Most of them are not. I mean, they seem to be okay, but they're rather passive. You know, they don't respond to the same information, and that could be a sensory route too. We don't know, but, you know, it's really hard to get them to engage. Barb,
I have a comment on that. You've seen home videos. I don't think the parents are going to videotape the babies when they're cranky, but I have seen videos at Community Krieger where there are some babies that are cranky and the parents are doing whatever they can. They'll still put their finger in the baby's mouth. They're doing whatever they can to calm some of the baby. So I definitely have seen that being an issue.
Right.
I bet Kate has probably seen that being working with feeding in infants too.
Oh, I'm sure. I'm just saying that when we look at them, it's not that they're, you know, a lot of our babies that we saw in video, they weren't cranky. They were even able to smile. they just didn't light up, as you said before. And I think that's important. And you have the parents constantly calling them by name, and you hear the frustration because they're not responding to the sound or their name. I'm not sure which it is at that age, but you know, and again, they don't really seem to pay too much attention to their caregiver. So that's a lot of it. And the variety of play is huge. They all play. I did not see one baby that didn't take a toy and play with it, but they tended to just kind of hit it repetitively, or some shook it repetitively, but you didn't see the same child shake, bang, mouth, look at it, you know, move it along the floor. I mean, all the things that babies do. So when we say repetitive behavior is seen, we have to realize that 6-month-old babies are repetitive when they play, and this looks entirely different than that. It is very obviously not just typical repetitive play of a 6-month-old.
And they're also not really responding, you know, like a typical development baby would be when the parent is talking to them and calling their name, not responding to the parent's voice.
Yeah.
So, let's see.
So we definitely need to work with larger sample size and work on, you know, we did some work on establishing the validity and reliability of our scale, and we certainly need to do more of that. We also need to determine the optimal age. Is 6 months the optimal age to be doing this? That's why I tried to move it to 6 to 9. And I think I was better with 6, but you know, we have to figure that out. We also want to go back and at somebody and look and see about how autism looks in girls, or how these babies are different than the boys, because I really do think that is an area that we're going to find some more work on.
And I think what, looking at 6 months of age, I do think a lot of these babies are showing subtle signs. I don't think you could diagnose that early, although they are showing that these babies are showing abnormalities in functional MRIs at 6 months of age, and EEGs, and white matter with diffuser transfer imaging. So they are showing abnormalities in the neural imaging, but I don't think we could diagnose clinically looking at behavioral observations that young. But the whole point is, if we see red flags, we definitely can intervene sooner to work to help focus on that child's strengths, and also to help them work on those challenges that they have to improve those co-occupations. So we're going to talk about some videos right now. So I'm just going to show you what we should be seeing in typical performance in prone at 6 months of age. And this is from the CDC's website. Learn the Signs, Act Early. So with many of our babies with autism, they're glued to they're stuck to the floor. They have difficulty lifting their head up, actually have poor proximal stability. And unfortunately, we're not able to show you a video of that right now, because we didn't want, you know, this is being videotaped. But a wonderful resource for you is Pathways, and it has a lot of beautiful videos of what is typical and not typical, and I would encourage you to use this as a resource. I'm going to show you kind of what, so you can kind of see the difference right here between the baby on the left, who has beautiful motor skills, and the baby on the right. We actually have seen children with autism at 6 months of age look like that, actually be able, maybe have a little less movement. I think those are things to consider. And again, if a baby's having motor issues at 6 months of age, we're not saying that baby has autism, but we were looking at high-risk infants who were at higher risk for it. We do know across the board that babies who may have motor issues early on, that can be an early sign the central nervous system is not developing appropriately. And it's kind of an early sign across the spectrum of developmental disabilities.
Doing some lower extremity kicking.
And of course, you know, there's a variation in normal development too. So it's just something you definitely want to monitor.
So this video coming up, I had, as Joanne alluded to, I had a wonderful video before this one. Oh wait, go ahead, watch her.
Hi. 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 Where's she go? Hi. Hi. Where's she? Hi. There she is. Hi.
So, I mean, I don't know about you guys, but I'm smiling as I'm watching this because, and I think we always talk about our clinical reasoning skills as occupational therapists. And, you know, we once, Joanne and I presented it at a big conference when during the days we were allowed to be in person. And everybody in the audience was looking at a similar video that I can't show because it's a real kid, you know, I mean, she's a real kid too, but she's already in a public venue. And every single person was smiling. And I would tell you to pay attention to that. Pay attention to what your gut's telling you, because you're going to watch another video now, also publicly available, child, same game, same age. And that, let's see what we have.
Family tradition to drive to that familiar beach house with familiar faces. And make the
Oh, that's not it. That's not it.
Hold on 1 second. Let me see.
Did we mix them up?
Let's see. You know, it must not be.
Oh, did we take it out?
I think we took it out.
Oh, that's a shame. Well, do we want to search? Can we search for it or no? Just because it's 10-month-old peekaboo. Well, anyway.
Yeah.
I'll
tell you what happened.
I'll tell you what you would have seen if you saw that video, because I think it's important. You would see the mom trying to play peekaboo, and she's saying peekaboo, peekaboo, and you're getting, you know, maybe a half smile occasionally, but nothing from the baby. And you hear her voice go, you know, as she gets frustrated that she's trying to get the baby's attention. If you search on YouTube, 10-month-old with autism with peekaboo, you'll be able to find it, and I think it's worth it. This little guy's that's coming up. Go ahead. I was just going to give the
send them
preface
the
to this
link
group.
so they can look at it, Barb. We'll send
I can do that. I'll send it to Kate. I'll send you the link to Kate. This little guy that you're going to look at, though, is he hits his motor milestone. So I think it's important that you look at him and realize there's still something going on, even though he would pass the motor test, and he did. Do you volume on, because the mom talks during this one?
It should be on, but again, this baby's not saying much. So, I mean, this is
Yeah, but the
something
mom talks to him on the video, and I think it's important to see that.
I do have the volume, I think, is on.
Okay.
Yeah. The baby's not making noise, doing some repetitive movement.
Where's your toy?
There's mom.
On the ground. Get your toy. Be careful.
And you notice mom's talking, and he looks at her, but he doesn't give her a lot. At some point, he's going to smile at her, but still not that bright smile that you saw in that little girl.
And it's not that integration that we see with that vocalization, the eye contact and the smiling that we see with these typically developing babies.
And I think you probably don't need to show the rest of it.
Okay.
Keep pillows around the table.
So here are several resources. The CDC Learn This Science Act Early. They actually have, and this is Kate's area, so I'm not going to go into detail with you, but they have whole wonderful areas for tracking milestones at all different ages, and then parent activities that you can give for children you see issues with. Also, the SPD Foundation has early red sensory flags you may see in children. And again, this is not indicative of autism, but it'd be concerns that you want to look for children. And then Pathways is a wonderful resource, looking at typical and atypical movement. And there's also another resource here by a physician where he talks about what you see motor-wise with newborns, developmentally, 3 months, 6 months, 12 months. So there's videos there for you to look at as nice resources. So I want to thank all the families who participated in all our studies, the principal investigator at Kennedy Krieger, Dr. Landa, my dissertation committee, Dr. Delaney, Dr. Lisa Crabtree, Dr. Patty Levesser, Dr. Rick Parente, Dougleen Jackson, who's an OT who coded for us for inter-rater reliability, Dr. Cynthia Lee and Dr. Teresa May Benson, the REACH staff, Dr. Margaret Bowman, who is a pediatric neurologist in Boston. Kate might know her. Dr. Anjana Bhatt, and funded agencies for the HEADLAG study, NIMH, Autism Now, and Karma Foundation, Dr. Susan Knox, Dr. Lucy Jane Miller, Dr. Sarah Schoen, and also the students that work with Barb.
Yeah.
So we want to thank you so much for your time and see if there's any questions.
This is really great. I have a quick question. When you were talking about the infant motor engagement scale and you were needing recruits, is that something that are you looking for children from across the globe? Would you like me to send out?
That would be wonderful. I will give you a flyer. I'm in the process of moving. So I will be leaving UTMB in the fall, at the end of the fall, and moving to Florida and be teaching at NSU. So my email is going to change. Barbara, is your email pretty consistent?
My email is consistent, yeah.
Okay. So
Very consistent for the
that
last
would be
20
wonderful, because we really, you know, it takes a village, and we, you know, if you're interested, we would love to be able to try to get more kids, especially children throughout the world. And, you know, I think OT can play such a unique role in this, and looking holistically at these children and looking at those qualitative issues. It's not whether they're meeting those developmental milestones, but how they're moving in the environment, how they're playing, how they're interacting with their parents, which is so important. And I think we have such a unique skill set to bring to the table and to evaluate that and to help these children with their strengths and challenges.
And yes, we will give you a PowerPoint. I saw a question come up in the chat. But I just want to reiterate what Joanne said about us as OTs, about all of us, of what we can contribute to this, is that we've been frustrated that there have been literally 20 years of studies looking at early identification of autism, and they exist in studies, but there's been very little that has been done clinically. So I feel like each of us has a role in that, and to really look at these early development and to look at it holistically, because I think OTs have special skills that researchers in other fields, which is where the majority of them are, they don't have that skill to look at quality of movement as much as we do, and quality of play and quality of interaction.
So we first submitted the HEADLAG paper. We were aiming for the stars to a pediatric journal. And I had so many red marks in it, because they're like, why are you looking at motor in babies with autism? This, you know, they don't have motor issues. And this was before 2010. And so really there's been a big change now. People are looking at motor and realizing the importance of looking at motor in these little ones. But I do think clinically we bring a very qualitative, skilled eye that can pick up on these qualitative issues. And if we could intervene sooner, we could really help out with these little ones and their families.
So Nora from Kuwait has a question in the chat box, and she's saying, what are the red flags that make us telling the parent to visit the doctor to diagnose or get checks? And thank you for a great presentation. So if you were to say like top three, like head lag, lack of babbling, like what would you say were the top three red flags?
One that I pick out, if I may give, would be the smile that isn't, like Joanne was talking about, this dance that parents and their babies do with this bright smile, like we saw in that little girl. A lot of times you see a smile, but it's not that kind of engaged smile, that love affair between the parent and the child. You don't see that. And that, to me, I have seen it in every single child that had a diagnosis, and have seen that big, bright, beautiful smile in every single typical child. You know, so I think that's one of the things that are huge. And regarding the caregiver, wherever you are in the room, I keep looking for mom. So if I'm playing by myself, I may touch base and smile at mom. You saw the little guy that we just looked at, and mom was there, and when mom talked to him, he acknowledged her, but there was very little interest in pulling her in, and I think those are two big ones. Go ahead, Joanne, you can pick yours in
I
addition.
think with that too is how hard that infant's having to work to engage, how hard the parents having to work to engage the infant. And I feel that the studies I have done have really been looking at high risk infants. So with Barb has really, I think we need to really be looking at the population of kind of high risk and low risk infants. But you know, in my study with the high risk infants, motor was so prevalent across the board. These babies not moving. So we definitely need more studies and really to see how. You know, if we were to screen in the general population, would we also see that in babies who are later diagnosed with autism who don't have a sibling with autism? But I would definitely say motor. And then just, you know, it's not whether or not that baby is making eye contact, it's the quality and presence. So I would say that the integration of that eye contact with the smiling and the vocalizations, these babies are not really babbling.
That's true.
And at 6 months of age, we see that. And as they get a little bit older, it's still there. Like Dr. Lando was saying at 14 months of age, it's that integration. They're not smiling and communicating and making gestures. Well, I think at 6 months of age, we're also seeing these babies not integrating the smile with the eye contact and the bab. So I think there's also I think there's subtle core features at 6 months of age that we want to monitor, and we could bring up the CDC red flags, say, hey, you know, these are we always want to start with the strengths of the child and then talk about, well, you know, I'm not really seeing this much. Why don't you talk to the doctor about this? But I think that's a good resource to bring up with the parent. Why don't you talk to the pediatrician about this and ask him or her about that?
Thank you. We have a couple more questions in the chat box if you have a minute.
Sure.
Joshua from Cyprus said, thank you for the wonderful presentation. It was awesome. One quick one. Are repetitive behaviors not motor issues in autism?
I'm not sure I understand the question.
I'm not sure either. Josh, do you want to take yourself off mute? I know you had said that there was no repetitive movements in the children that were typically developing, so we should pay attention to that. Am I summarizing that correctly? Okay.
So are you trying to say motor delays versus repetitive behaviors, and whether there could be kind of a sensory, what would be the reason behind that repetitive behavior?
We'll give him a minute to type into the chat box. Okay. How about that? And then the next one is from Naya. She is from Zimbabwe. Do you have a short, simple screening tool that you use to pick up developmental delays, motor problems in practice? And thank you for the interesting presentation.
Thank you.
Thank you. Well, that's what we're trying to develop. So we don't really want to share it yet because we don't know if it's sensitive and specific. So we're trying to do a study where we're looking at more children. If it's sensitive and specific, we then want to make it available for free on the internet. But right now we can't say whether or not. Barb and I both think it really is looking at these target behaviors that we have seen ourselves. I've looked at hundreds of videos, and I really do think it's gonna give us some really valuable information, but I can't say that for sure right now because we're in the process of developing it and looking at the psychometric properties of it.
But in the meantime, do look at that slide that we have, you know, because it tells you the things to look for, and you know, you could create your own things to look at. But if you look at those items, and you are going to have this PowerPoint is going to be with you. It was one of the last ones where it says, in the meantime, here's what you look at. Though that will tell you the things that those are the types of things that we're putting into our tool. So that would help you get started.
And in the meantime, because I'm sure I will get a copy of that from you guys when it is finished, I do have the link to the free screener that was developed by Tufts University, the Survey of Well-Being. That screening tool, I do have a link on the OER page, and that is free, and that's really highly recommended. It's growing. It's sort of, I think it's going to be as sort of not replacing Ages and Stages, but it's really growing in popularity. So
actually, I would like to have that link too, because I'm not familiar with that.
I will email you.
Thank you.
You're welcome. Mo, I think this is Mo from Morocco, says any data that motor-based therapy can improve outcome following clear ASD diagnosis. So maybe, is there any data that
Well, I think that the early Denver model that they have actually looked, that is looking at behavioral approaches with developmental approaches. It's looking at sensory, motor too, and play-based, and they have shown changes in the brain with that. So I think, you know, as far as with autism, they have done early intervention therapy. I think a lot of it's more based on social communication stuff, but the early Denver model does, you know, look at play, look at engagement and sensory. And we know early on that motor provides the foundation for social communication skills. It provides the foundation for these babies moving and explore and interact, and for them grade in their movements to interact with their caregivers. So everything is motor, right?
But you want to incorporate motor into whatever you're doing, but I would never just take a purely only motor approach. Right. I mean, we want an integrated approach. We want movement in order to play, movement in order to interact with people and toys, and you know, so you want to incorporate that movement, but you don't want to strictly do movement. You know, I think it would be a mistake, because one of the things that I think is one of our major points is that it is a truly integrative thing, the movement with the social, with the play, these are examples of integrative types of activities, and here's where, and that's where the kids are really falling down. So I think that you want to incorporate movement into whatever you do. Don't just say, oh, it's a social communication disorder, so I'm going to avoid talking about movement. And I think that will get you in the right direction.
Two more questions. One is from Modesta in Ghana, and she's saying that if a baby's developmental milestone seems quite faster than a baby of peers, than his peers of the same age, is it something you should be worried about?
Not necessarily, no. I mean, you're saying his development is faster? No, not at all. But I want to point out that the little Raphael, which is the baby that was the last publicly available little boy that you looked at, I mean, his milestones in terms of motor were ahead, and he did have an issue. So that's not in and of itself a cause to worry at all. But just because they're hitting all their milestones quickly doesn't mean that they're totally fine either. So it's the kind of thing, you want to consider all the things that you're looking at. You want to use all your observation skills, but I would never be worried about a child who's ahead of the game just because he was ahead in motor, unless he demonstrated other signs like Raphael did.
And I want to add on to that, because in my first study, I said that all the babies with autism had motor issues. And the second study, when I looked at play, there was, I was blind like Barbara was blind. So I was blind to the risk status. I was blind to the diagnosis. On the second study, there were a few babies that were the same babies from the first study. So I had Barbara code them because Barbara was blind. So we made sure that we were blind all across the board. And that didn't affect how we judged, how we scored the babies. But there was this one baby who was a total superstar. And I had no concerns across the board about this baby at 6 months of age. And when I finished coding, I went back and I wanted to look at the babies who had autism. And I was shocked to find out that baby had autism. And I really wanted to go back and study the tape to see if there was anything I could have noticed at 6 months of age. But I still feel like we still need to learn so much more. You know, there may be babies who don't show any signs at all at 6 months of age, and maybe don't show it until 14 or 24 months of age. It could be a late onset at 24, 30 months of age. I don't know. But so just because a baby's not showing or showing advanced motor issues doesn't mean they might not have problems later on. I just, you know, every baby's different, but we definitely want to, you know, kind of keep an open mind about all that. And even if a baby is showing motor issues, they may just be a late developer and may turn out to be just totally fine.
And of course, a preemie is going to have some of those motor signs, and then that doesn't mean they have autism, of course, but just because they're premature doesn't mean they don't. You know, so there's just so many factors. So the best we can do is make note of these things and address them. early, whatever the cause. And that's sort of one of the reasons I don't get too excited if I don't have another disability group, because in reality, if we flag a kid as needing something, needing maybe parents need coaching, how to interact and how to facilitate motor skills or whatever, we want to get them the help they need. There's no reason that I have to have confirmation that this child has autism or something else. If we see a sign that something's up, we want to try to intervene in some way to facilitate the development, and that's the important part, and facilitate the parents being able to successfully interact too.
When I think going back to that website, CDC Act Early, if you see a little bit of a concern, show the parent that website, give them the activities on that website to work on, and monitor the baby. I think we need to be careful about not super, worrying the parents and alert. We want to monitor and then maybe see them in another month or so. See if the pediatrician can monitor them. But if we're seeing hits that continue and across the developmental domains, definitely that baby needs intervention.
Great.
Great, thank you. All right, so our last question is from Josh, and Joshua, he's following up on the previous question about the repetitive behaviors. So what intervention methods are there to help improve the repetitive behaviors?
You really just want to foster play. So, we're looking at these in very, very young babies, but when we see it, you want to help the baby learn how to play, show them different things that a toy does. And that's the first thing you would want to try to do there is, oh, you have this toy, let's do this. Ooh, look what happens when we do this. What happens when and have them start to see that there's other things that you can do to play. But that's just the beginning. There's a number of other ways you could go with that.
And I think it also, you wonder why that child has repetitive behaviors.
Yeah.
So you kind of want to know why, but I am DIR 4-time trained. And so a lot of times if a child's doing something repetitive with a toy, I might start where they are out to engage that child. And if they're doing something repetitive, I will do what they're doing. And they'll look at me like, oh my gosh, you get me, you're doing what I'm doing. And we develop this rapport, and we expand that play repertoire by first becoming play partners.
That's a good point.
Well, thank you so much, both of you, for this presentation. This was absolutely wonderful. I really appreciate your time.
Well, thank you so much.
We enjoyed being with you guys.
Thank you.